Hello and welcome back to my session. We finished gallbladders and all about gallbladder in the series last time, and then we took a break. We talked about a book which is called Doctors the Living. We spoke about the book, and I hope you all have enjoyed the video that was at the end of the session. Now, in today's session, we will start with hernias. Hernias, as you know, if you define a hernia, it is a protrusion of a viscus or part of viscus through an abnormal opening in the abdominal cavity. So that is the definition of a hernia. There are a lot of hernias, of types of hernias, in which we can talk about is like inguinal hernias, femoral hernias, then you have umbilical hernias, then you have incisional hernias, epigastric hernias, and then you can also have hiatal hernias. So we will start with the inguinal hernia. Now, as the name suggests, inguinal hernias are seen in the inguinal region and on both the sides. They are most common. Up to 70 to 75% of all hernias are inguinal hernias. So it is mandatory to understand what is the anatomy of this, what is the epidemiology, what are the risk factors, what are the contents of this hernia, and then other descriptive stages we will go through step by step, and we will talk about these hernias because it's a common problem which is faced by a lot of people in the adulthood also. Above 75 it's very common. It's about 200 per 10,000 population you get this hernia above the age of 75 years, and below that between 16 and 24 years about 11 in 10,000 have this problem. So starting with the hernias, if we start with the inguinal hernia, we will talk about the anatomy first of the inguinal hernia. So to understand the anatomy, we should know that the right and the left iliac fossa regions and the hypogastrium, the areas above the pubic rami, are the ones which are getting affected here. So what exactly is happening there? When we talk about where does the hernia come from? The hernia is a protrusion of a viscus or a part of viscus through an abnormal opening in the abdominal cavity. That means something from inside is coming out, is trying to come out through certain layers which are otherwise protecting it from coming out. Okay? So what happens, but there are certain potential sites within these layers which affect the actual process of trying to contain the contents of the abdominal cavity. Now for that there are two rings. These are anatomical ring structures which are present. One is called the superficial inguinal ring and the other is the deep inguinal ring. Now, where is the superficial inguinal ring? Superficial inguinal ring is nothing but above and medial to 1.25 centimeters above and medial to the pubic tubercle. And where is the deep inguinal ring? Deep inguinal ring is in the mid-inguinal point about 1.25 centimeters above that. And that is, what is the mid-inguinal point? That is the midpoint on the inguinal ligament between the anterior superior iliac spine and the pubic symphysis. So that is the mid-inguinal point. One is the midpoint of the inguinal ligament. Okay, so that is different. What we are talking about here, that is from the ASIS to the pubic tubercle. That is the origin and the insertion of the inguinal ligament area. That is the inguinal ligament. Not exactly origin and insertion, that is the extent of the inguinal ligament. But if you go, the mid-inguinal point is from the anterior superior iliac spine to the pubic symphysis, midpoint. Okay? So, deep inguinal ring is 1.25 centimeters above that, mid-inguinal point. So, this is a slight difference between the two, but nothing much. Now what happens is that deep inguinal ring is up to the superficial inguinal ring is what we call as the inguinal canal. Now this inguinal canal is approximately 4 centimeters in size. Okay. Now what are the fibers that are making these rings basically? We have to know that. Okay. So the superficial inguinal ring is a structure which is present within the external oblique aponeurosis. So that is the grooves above and below are from the external oblique aponeurosis, while the deep inguinal ring is formed by the facial transversus. Okay, and somewhere between these two is what we call as the inferior epigastric artery, which is medial to the deep inguinal ring, and that becomes a source of significance between the direct and the indirect hernias, which we will talk about later. Now, when we talk about these hernias, we have understood what is superficial inguinal ring, we have understood what is deep inguinal ring, and the region from the deep to the superficial inguinal ring is called the inguinal canal. So, naturally, the body will not like to have a hernia, okay? So, the body is trying to prevent it. How does it prevent it? This canal is oblique, so nothing straightforward can drop from one deep ring to the superficial inguinal ring. This is an oblique canal. So, and secondary, it also has a shutter mechanism for defense against the formation of hernia. Now, this shutter mechanism is formed by the conjoint tendon, which is formed by the internal oblique and the transverse abdominis muscle. Okay. Now, what are the boundaries of the inguinal canal? Now we come to the boundaries of the inguinal canal. You have superior, inferior, anterior, and posterior. The anterior boundary is formed by the external oblique aponeurosis and the conjoint muscle laterally. The posterior boundary is formed by the transversalis fascia and the conjoint tendon. The superior boundary is formed by the arching fibers of the transverse abdominis and the internal oblique muscle, and the inferior boundary is formed by the inguinal ligament and the lacunar ligament, which is a part of the inguinal ligament. Now, what are the contents of the inguinal canal? The contents include your spermatic cord, then you have ilioinguinal nerve, you have the genital branch of the genitofemoral nerve, and the round ligament in females. Now, what is the spermatic cord made of? Spermatic cord is made of your vas deferens, your testicular artery, cremasteric artery, and then you have the pampiniform plexus of veins, and you have the lymphatics there. So these are the boundaries and the contents of the inguinal canal. Now, if we go, what are the types of the hernias based on this anatomy? Then you have the direct hernias and the indirect hernias. Direct hernias are caused by an area which is known as the Hesselbach triangle. Now, what is this Hesselbach triangle made of? The boundaries of the Hesselbach triangle are medially you have the lateral border of the rectus abdominis, laterally you have the inferior epigastric artery, and below means inferiorly you have the inguinal ligament. So any structure that passes through this potential defect in the anterior abdominal wall through this triangle will cause what is called as a direct hernia. Indirect hernias are those that pass through the deep inguinal ring into the finally inguinal canal, superficial inguinal ring, and then may extend into the scrotum. So they may be incomplete or they may be complete depending on the site of where they are present at the time of presentation. Bubinoceal or funicular type. Okay. Then we move on. What happens when a content from the abdomen goes through these canals, through the inguinal canal or the hernia which is present there? You can have 5 types of presentations there. You can either be a reducible hernia or an irreducible hernia. It could be an obstructed hernia, it could be a strangulated hernia, or it could be an inflamed hernia. Now, what is a reducible hernia? A reducible hernia is a hernia that can be reduced spontaneously on its own. An irreducible hernia is not reduced spontaneously. Okay, so any hernia that reduces itself on its own is a reducible hernia, which does not reduce on its own is an irreducible hernia. Then thirdly, what we see is obstructed hernia. Now, what is an obstructed hernia? That is we go step by step. So reducible, irreducible, obstructed. Now, obstructed is that irreducible hernia which has intestinal obstruction in it. Then what is the strangulated hernia? A strangulated hernia will be that irreducible hernia that is now obstructed and has a compromised blood supply with it. So anything that has a compromised blood supply and has an obstruction present becomes a strangulated hernia. Inflamed hernias are those hernias in which you have an additional appendicular appendix is there, Meckel's diverticulum is there. So when these get inflamed, it forms an inflamed hernia. If it gets gangrenous, then it forms in strangulation becomes incarceration. So these are the clinical types of hernias which we know now. Now, as we move a little further, there are certain points, salient points which we have noted that about 7% of all surgical OPDs will have this hernia, problems with hernias. They are usually seen more commonly in age group of 75 and above, when there are about 200 hernias out of 10,000 hernias, and in the age groups of 16 and 24, in which you have about 11 per up to 10,000 hernias, 11 of your 10,000 hernias. And then what you have is it is more common on the right side because there is a delay in the testicular descent on the right side, and also there is obviously a delayed closure of the processus vaginalis, obliteration of the processus vaginalis on the right side. So it is more common on the right side. It is more common in males, 9:1 ratio male is to female. Then the risk factors which are present is like in infants it is because of prematurity and males, whereas in adults it is like males, and then there is obesity, there is constipation, urinary obstructive symptoms, and then there is smoking, which is causing this hernia. So anything that causes increased intra-abdominal pressure will cause your hernia. Okay?